primary care, surgery, end-of-life care. And we use the human-centered design approach. We're data-driven, but we're not just bound by producing the usual stuff that academia produces, which is papers. About half of our work is in the US, half is abroad, and we really aim to distribute useful tools that reduce suffering everywhere. So that's our spiel. We're a collection of about 100 clinicians of all types: nurses, doctors, statisticians, qualitative researchers, designers, architects, urban studies folks, all sorts of interesting project managers, all sorts of backgrounds. And we work collaboratively. We're really excited to be doing this work together and hope that it's useful. Parabola project, for those of you who love math, we're trying to minimize and flatten curves of risk. We're trying to maximize and increase parabolic curves of educational benefit. All parabolas, which are amazing mathematical functions, have a focus point. Since we have two parabolas, we have two focus points. Our focus is really on that which minimizes health risks and maximizes learning. We can keep getting into great analogies of why parabola around the fact that the back of your eye is a parabola, how you see, it focuses your vision, but that's maybe for another time. So for the last 6 or 7 weeks, we've had the privilege to work together with TLA on this work, and we've put together a guide. And let me just offer a few thoughts with humble addenda to your intro, Nate. It's actually not a guidance. We want to make sure that you understand that the guidance that you receive is actually from your local, state, and federal sources. And though I wish it were different, and I'm sure you would love for me to tell you at what level you can safely reopen your districts of COVID transmission, it's not, unfortunately, as simple as that. But what we can do is, instead of giving you a checklist that gives you a false sense of security, or try to replace in an inadequate way a state or federal guidance, what we can do is synthesize and present to you a set of implementation options for you to think about your readiness, capacity, interest in, and ability to safely or more safely reopen schools. We can also help you think about a way to have a comprehensive view of risk that's inclusive not just of COVID-19 risk, but of other risks, so that you and your communities can make excellent decisions that bolster trust. And trust is really in short supply, I think we could all say, across the nation right now. I looked at the map of where you all are working and living. I have connections, strong connections to many parts of that map. After I moved to the US, I lived in El Paso, Texas for many years, have family there, which of course people think that, Texas, oh, you're from Texas. And we all know, Austin, that Texas is not exactly a small state, but I know a little bit about Texas and have lived there for a while. I also lived in Rochester, Minnesota, not too far from Cedar Rapids, Iowa. So yay Midwest and corn and many cool things about the Midwest, and went to medical school in San Francisco. So hello, Monterey. Obviously live in Boston, so hi Phoenix, and for Indianapolis, Philadelphia, and Seattle, visited all of your lovely cities. Why am I saying that? Your contexts matter, and we're gonna help you preserve and build that key area of capital that you need, which is trust with your communities to make the best decisions possible. So that's why this is a guide that won't give you the answer. But also will not try to be an oracle of Delphi and give you these sort of impossible to discern, maybe I should or maybe I shouldn't, or what do the tea leaves and the bones say, where it aims to be concrete and pragmatic. And so let's talk about how it does that. Next slide, please. It's really oriented around a set of 9 public health principles, which we have gleaned from our work in healthcare, from our experience dealing with this pandemic. I'm a practicing primary care physician. I'm an internist. I have been, quote, on the front lines, though I don't love the war analogies or metaphors. And actually one of our faculty Mary Brindle, who's the head of our surgery team, published a beautiful article about why the war analogy doesn't really fit with COVID. But nonetheless, I can tell you from personal experience, it's been not pleasant, and I'm sure it's not pleasant in many of your communities right now. So in the process of understanding how one reopens workplace environments safely and one approaches this from a public health point of view, the good thing that we can offer you is the idea that there have emerged really a set of interlinked, overlapping, augmenting common principles on how to do this stuff more safely. And so we've gathered those and then really tried to adapt them to the education space with our partners at TLA. And that's really how the guide is oriented around these sort of parameters of, we think, a pretty comprehensive view of the things you would need to consider as you think about progressively increasing in-person learning. Next slide. Those principles key off of the idea that there is, at the center of this slide, massive COVID-19 risk. We know that. We're all here because of that. Our society and lives have been upended because of it. But it's nuanced and it's complicated, and it is, and what emerges for the education space is a plurality of evidence, and evidence changes weekly. And, you know, it's hard, I know, for the public and for non-health folks to see the process of public health and clinical science happen in front of us, which is actually a very messy, disconcerting, stop and start, learn and then draw back, a couple steps forward, one step back. That's how science gets made, and that is challenging in an arena in which we don't all agree on facts and on the scientific method, and a lot of people are choosing their own adventure when they think about facts and science, and that's made confusing when what has been thought of as conventional wisdom one week gets upended the next. But with those caveats there, what emerges is it appears that children, especially those under 10, have milder cases of COVID and probably transmit less. New research, even as of last weekend, suggests that older kids, especially middle-aged, middle school and high school kids, biologically and functionally, at least immune system-wise, if not behaviorally and making executive decisions, act more like adults and may actually transmit virus at rates more closer to adults. So what that means for a school setting is that your high schools and your upper middle schools are actually probably bigger risk centers than your elementary schools. But, you know, it's not all about COVID, as you know, and we just want to name the risks that we're all trying to balance here, because there's a risk of overemphasizing risk just in the space of COVID. There are learning loss risks that you know more about than I. There are socio-emotional health and learning risks that we see as educators, as parents, as health providers, around anxiety, depression, loneliness, just the bizarre, kind of unusual circumstances that we find ourselves in right now. We have concerning studies emerging about potential increases in traumatic child abuse as measured by rates of admission to ERs for head trauma for kids. Now, most of those admissions admittedly happen in kids under 5, but not all. And we know that we're missing a lot of cases of child abuse and neglect by not having in-person learning. Nutritional insecurity is a massive issue. We know schools provide food to up to 20% of kids across the country. Lack of employment because of childcare capacity is a major issue, and lack of access to the services that are essential for kids, especially those with differential or special needs, is a major challenge and loss when schools are closed. So there's a risk of COVID-19 transmission if schools are open. There's a risk of a bunch of other stuff that you know, or maybe might want to think more about if schools are closed. And that, again, doesn't tell us exactly what to do, but at least frames a more nuanced conversation than I think perhaps is happening in many communities right now about what we are trying to mitigate and what we are trying to maximize. Next slide, please. So with that view, let me walk through the 9 principles and sort of just lay out what they are about and then what devolves from them in a more pragmatic implementation way. So the first is really around how to think about leadership in a time of crisis, in a time of public health crisis. Leadership that requires attunement to data, that requires trust, agility, and a global view or a balanced view of risk. We also think about risk stratification, and risk stratification is around the stratification of risk for COVID. Who are the learners and the staff members in your school environment for whom COVID is actually too much of a risk to submit them or expose them to in-person interactions, even with the other mitigation mechanisms. So there are going to be a not insignificant number of learners and staff who have a set of specified and identifiable chronic conditions, immune conditions, cancer diagnoses, uncontrolled chronic disease for whom the risks of being exposed are just too high. It's important to understand those and to help those folks not be in in-person environments. There's also another angle to prevention, which is really about not forgetting the essential preventative services that we need to continue in order to have in-school learning, which really revolve especially around immunization, influenza, but also the common childhood immunizations so that we don't have to deal with concurrent overlapping epidemics around pandemics. Another key principle is the idea of screening and triage mechanisms. When I show up to my work environment, after that work environment has sufficiently taken out some staff members for whom in-person work is too risky, and who have leadership that's attuned to data and local transmission dynamics, the next thing is that there's daily screening for symptoms that would suggest risk of COVID-19 or recent exposure to people who have COVID-19, and a connection to triage mechanisms to either get them the testing and tracing that they may need, or if a child or staff member presents with symptoms during the school day in person, there's a triage mechanism that can safely evaluate them with the proper equipment. So this connection between screening and triage and testing and tracing is part of an important continuum, and part of the issues that get back to leadership and culture around connectivity and routes of knowledge and data transmission between your schools, your school leadership, and your local health boards and health testing capacities. Does that mean that schools become testing sites and need to test all of their kids and staff? I think that's unlikely to be the usual circumstance. There are districts that are keying in on the need to make schools have a testing capacity, but I don't think that, the way I look at it is that there's enough that's on schools' plates before getting into the world of testing and tracing. Let the public health departments and state and local authorities and health systems be leading on that. Next slide, please. These principles really have to do, these 5 remaining really have to do with important mechanisms to mitigate in-person transmission in the classroom and in the building. So we know that masks and other personal protective equipment are critical. We have all sorts of information here on what kind of masks, mask breaks, how to change them, how to think about them, and also the more specialized protective equipment that we really think, you know, school health and school nurse officials need to have, especially to triage people who may be suspected of having COVID or develop symptoms during the day. We spend a lot of time thinking about hygiene, both on the person and hand washing level, but also on the space level, how to clean hands and clean surfaces to reduce exposure, and all the technical details that might be helpful to your ops teams to think about how to approach this problem, from frequency of hand washing to type of hand sanitizers to you know, frequency of surface cleaning, and also things not perhaps to invest in, like plexiglass barriers within classrooms, which may actually be as much a nidus for infection if they're not cleaned regularly than any sort of perhaps not so useful mechanism to reduce what's mostly an airborne, aerosolized or droplet disease. Density and distance are hugely important. The principles of how to lay out classrooms and spaces and how to keep the density of groups in enclosed spaces limited to reduce the risk. A lot here about how we think about the number of feet between people as a goal, as part of a continuum of risk reduction. Higher is better, but higher also means less kids and people in an area. And so that is a complicated dynamic. And you know, for instance, some states like ours have a lower set point of distance between people than I think we believe the evidence suggests is safer. So we would aim for 6 with the understanding that that makes your lives as educational planners harder, but also remember what we're trying to produce besides reduced risks and maximize learning is a sense of trust in the internal school environment that will enable more learners and more teachers to want and be able to come in regularly to learn. So trust is a currency we're trying to use and produce in addition to learning and lower risks. And we do that by perhaps being more conservative and more careful, especially in zones of high transmission. And that's one of our framing principles, or framing concepts here, is that if you are in an area that has high or rapidly rising community level transmission, even the maximal enactment of all of these principles might still not be enough to make the reduction in risk sufficient to enable in-person learning to happen on an everyday basis. If you are in a low and stable rate of transmission in your community, that becomes more possible. And remember, those are dynamic. So it might not look low and stable now. You may be in high and increasing, but with the right community mechanisms, that could change by September. So this isn't just one decision that you'll make at one point, it's an iterative decision. And so you're probably thinking, what's the number? We're really trying to work on figuring that out. I'm not comfortable giving you a sort of threshold number, except to say that on a county or state level, if you look at a transmission rate over the last 7 days, transmission rates in the hundreds per 100,000, like right now, parts of Florida, much of the South is in the 200 to 300 cases per 100,000 per 7 days. That's way too high in our minds. We are aiming for low double digits, or single digits. Now, there are not that many places in the country right now that are in low double digits at the county level. There are, some rural areas, some places in the Northeast, Vermont, Hawaii. But those are the kinds of numbers, 30 per 100,000 per 7 days, 20 per 100,000 per 7 days. If you want to know where you can look up yours, you can go to New York Times and they have like a map with all the counties, and many of your counties are not at 20 and 30. In fact, in the question and answer, I'll look it up. So does that mean that you can't reopen at all? No, but it means you have to be really careful and you have to think creatively and make sure that you've also been addressing each of these areas, including the 8th, which is space layout and air quality and all sorts of ventilation tricks and getting your ventilation rates up, thinking about danger zones like bathrooms, exchanging fresh air as possible, increasing MERV filtration if you have it. These are all complicated issues which you may not be able to solve right away, but you can probably, with concerted effort and reduced community transmission, get to soon enough. And then the final area is in cohorting, thinking about how to not have groups bump into each other more than necessary, aiming to limit group size to 25 or maybe 30 or less, not using open spaces like gyms as, 4 classrooms unless you've subdivided the gym with floor to ceiling walls, because again, we're trying to reduce the principle of lots of people exchanging air even while they're masked, in order to, reduce transmission. So those are the 9 principles. We can sort of get into the next layer of detail. Next slide. Those principles splayed out onto a TLA conceptual framework that thinks from outside at a district leadership level. Second rung in is at the school and school leadership level, and then closest rung to kids and adults is in the classroom level. You can kind of start to see where those principles kind of align to on their locus of action and control. Next slide. So here's where the guide exists and lives. It'll not have a password soon enough. Next. And what it does is really identifies these 9 principles, provides a set of options and practices on how to build a shared understanding of risk, but also build a sense of action toward mitigating that risk. And it's not a checklist, and it's not a you must do every one of the 78 things in order to feel that you can reopen your school. It's you should really look at each of the principles and sub-principles and ideally either have a plan or be able to address many parts of them. But it gives a lot of optionality in terms of looking at best practices from across the country and across the world. Gives you starting point tools and a sense of direction and a sense of monitoring your progress toward that direction, what will inevitably be at least a year-long process, if not more. Next slide. So let's dig down into one of the principles, hygiene, both at the personal space level. You see a quick definition of what it might be. And you can see the sub-objectives starting to break that down into more detail. Next slide. Then you see within each sub-objective the implementation level. So for plans around hand washing and sanitizing, we would think that that would be at the district level. You want a status bar and then a prioritization bar that helps to prioritize it with where you are in your journey and with your competing demands. Again, we didn't want to say to districts that that there's sort of one thing that's more important than the other. They're mutual overlapping, mutually reinforcing principles. And so really they're in a way they're all important, and you grading when and how you address them is really contextually bound to your situation. We then list key recommendations for your consideration as you think about implementing this objective, and those are listed below. And then we start digging deeper and deeper. In the next slide, we take those recommendations and turn them into what are some starting point tools? Where can you start a discussion if you haven't on this? What are the parameters you may want to consider? What are some of the tools you may want to start with, like from the CDC or from other mechanisms? And then we'll have in development, iteratively issued week after week, both health and education deep dive toolkits that help think about, for instance, how do you structure a hygiene break in a classroom setting? How do you think about structuring that? How do you think about structuring mask breaks? What are the pedagogical and health details around that consideration? So we're getting layers and layers of deeper implementation specificity and optionality. Next slide. Then there are other resources that drop down from this, including specific examples from all over the country and all over the world, ideas on areas you might want to stretch in implementing in, and then guidelines such as they are available. There's a progress guide that allows you to sort of track yourself where you believe you are and kind of keep everything in one page or spreadsheet. Next slide. And then deeper dives around, again, these these are examples that TLA is developing on, think of these as sort of 4 to 7 page real deep dive modules on something even more specific than what the guide is offering. Beth and Jinsu, I don't know if you wanted to go in any depth here on this.
The only thing I'll say is, so we've been trying to lead from the principles and then overlay them with what we know are probably operational challenges you all are facing and figuring out how to actually put those practices in place. We have a planned set of released guidance. These are the first 2 that we've drafted, but tackling things such as family and staff communications, thinking about return to school, diagnosis, intervention, both on the academic side, but also the socio-emotional side.
Yeah.
So we have a prioritized list, and we can share that with you all. If there are gaps or things that are hot points for you, we'd love to hear it, because we're making best guesses based on what we're hearing from Massachusetts, but we regard you all as some of the leading thinkers in the country as you're trying to figure out your school plans. So please don't be shy. I know you aren't shy, actually, knowing all of you, but.
Yeah, and we're almost done with me prattling on here. So welcome questions, feedback, directions for development, etc. Next slide, perhaps, and then we'll try to finish. There we go. So that's sort of a quick layout of what it is that we're doing. I think I'll sort of turn it over back to you, Jinsu, Nate, and move with the poll here.
Great, yeah, so before we jump into, we're gonna use a poll to quickly identify 1 or 2 of these to go much deeper with, but would like to open it up if there are general questions about the principles overall or about the guide that's been created that people have before we do that. And would encourage folks to put those into the chat as we go as well, but it seems like we're ready to jump into some specifics. So I'm going to start a poll in Zoom. You can go ahead and vote for which one of these principles is top of mind right now that you'd really like to discuss. And we'll take about 6 or 7 minutes to go deep with this, and then we'll do this hopefully one more time before we close out. Wait for a few more people, I believe. Last chance. And closing poll now. And I'll share the results. You should be able to see. It looks like cohorting and scheduling was the top choice. Would love to go deeper with that. Asaf, if you'd like to give us some initial deeper thoughts around that, or we can open it up for questions to begin with around that.
Well, I'd love
again, cohorting and scheduling.
Yeah, I'd love, I mean, I don't want to keep, you know, on a soliloquy here. So happy to make this more interactive. There are not that many of us on the call.
This is John from Cedar Rapids, and I'm willing to not be shy.
Super.
We've been meeting with our staff and community really in depth over the last few weeks on the current draft plan we have. And the stickiest part, whether it's elementary, middle, or high school, is definitely the cohort and scheduling, and the part that gives our parents most concern. And just for the context here, our parents have a choice of in-person learning in a cohort model or virtual learning, and they can pick that for the semester, for the year. I think what I'm worried about, one, is our high schools, and our cohorts don't work as well at the high school level because teachers are exposed to still 140 kids, maybe in a week or a 2-week period, where at the elementary and middle level, we're able to confine down to 20 to 1-ish. And so our high school teachers are really struggling with this kind of safety concern and potentially may not return in large numbers, which would put us in a spot. And then secondly, our middle school families have said, when we're in a cohort all day long to limit exposure, we're not getting a really high quality experience. It's basically virtual learning in a middle school setting with a babysitter all day. Help us understand why we would want that option. So those are some of the challenges we've had, just, you know, numerically, math wise, staffing wise, to make cohorts work. Although I totally agree that's the way we need to go.
I agree with you that the middle school and high school examples are a real conundrum, like 2/3 of your kids, right? So that's not super helpful. I think that there are two ways to look at this. Number one is that if I may be so frank, I mean, from what I understand from you as our education experts, in-person learning might be more important, should I say, for younger kids than older kids. Now, I'm not talking about what's ideal and what's maximizing for pedagogy. I'm talking about what's possible for the situation that we all face as a society right now. If we had to choose, my question to you would be, would it be reasonable to assume that prioritizing in-person interaction and learning for, let's say, K-6 or K-5 might be more important? It's not to say that middle school kids and high school kids are learning wonderfully online. We know that that's not possible, but given the cohort, it's a Rubik's Cube, and you know, either you expose teachers to 150 people a day in high school, or you have the babysitting problem, or you go to hybrid schedules, or you just say that, you know, certain English classes in middle school will just be online. Half will be online and half will be in person, and each person in their schedule will be, you know, will have a combination of both. So, you know, a middle school and high school kid could imagine, like, either on different days or having smaller days, just a few in-person things, and those in-person things would be different than their friend who would have other in-person things, in order to keep the cohort small. And there would be remote learning for, you know, for the other parts. And is that educationally optimized? No. But I would tell you, we think that the high schools are going to be your unsafest zones. And so given that, might that reflect a set of creative possibilities that you might enact to meet those needs? I'm sure that's a totally unsatisfying answer.
No, not at all. And our original proposal to our high schools was only 9th graders and students that were at risk come in. 10th through 12th, you're fully online. And then same at 6th grade, only having 6th graders come back. And then our governor told us last Friday that schools must be open, and students that want to come back need to be able to come back at least half the time. So I feel we're a little suddenly handcuffed in figuring out what is obviously, as you're saying, an unsafe kind of situation.
Yeah.
So we're trying to work within new handcuffs.
Yeah, I mean, one of the ways I imagine some of this guide could be used, or I hope you might find utility, is is a means for helping communities get to in-person learning when they are in a position to do so, but need that faith and trust to do that, but also helping communities and leaders of certain communities have a bit more of a reality check on, you know, I mentioned this yesterday to another group. You know, COVID-19 has a way of inspiring a very interesting set of overconfident reactions among certain political leaders. I guess I would call this everyone's got a plan for COVID-19 and how it's not going to be so bad for them until it's so bad for them. Everybody doesn't want to wear masks and thinks that they're smarter, better, you know, more clever than these 15 genes in a little ball of protein. But I can tell you, I do a lot of global health. There's not one country, there's not one person, there's not one community that's been too clever for COVID. It will humble your health systems, it will humble your communities, and political leaders, they always have a plan until they don't. Whether that's our president, whether that's some of our governors, They tell us masks don't work until they start wearing them when their hospitals get full. I'm saying this kind of a little bit as a grizzled healthcare veteran here. We did the same mistake in Massachusetts. We were banging on the door of the governor for 3 weeks when we saw this tsunami coming. And it was, oh, we can't really, it would be impossible to close. Schools can't really close. Masks can't really be worn. People can't really not go to the restaurant until they can't. And then they don't. And the only difference is what the cost is going to be. That's the only difference. So if your governor in Iowa wants to pretend that you can fully reopen high schools at the same level and without all of these safeguards and without thoughtfully considering cohorts and other things like you are talking about, then he or she, I can't remember if you have a he or she, but they will learn, hopefully sooner rather than later, that that's a mistake. And I think our job is to communicate not in an overly strident and scary way, but in a clear way that I guess the bottom line is this virus doesn't care what you think about it. It just works in math and biology. And you ignore that at your peril. On that, Upper, any other thoughts on cohorting?
And let's open it up for any questions at this point. I don't think we need to be specific with the topics, but feel free, whatever you got, please share questions, thoughts, feedback.
Hi, this is PK from Monterey. About screening and taking temperatures before people enter the school building, if we were to come back, either the hybrid or full model. We've heard from some local experts, and I kind of agree, that seems like a tremendous waste of time and energy because of the asynchronistic, or the, the people can carry it without symptoms. Just trying to get your sense of whether that's a practice that we should put time and energy into setting up operationally or not.
Yeah, great question. We really don't think that taking temperatures at the door is worth the effort and the risk. There's actually a risk, of course, in bottlenecking and clustering groups and making what's already pretty chaotic, getting people into buildings even more complicated. The reason is because of the asymptomatic transmission window of 5 days. A lot of people don't have fevers that are, there's a lot of debate about what's a fever. And people can, with these sort of non-touch thermometers, there can be reasons why people show a temperature that's not actually a temperature. So we don't think that that's worth your trouble. What we do think is some sort of system, and here there are more options than clarity, around asking parents and staff to enact a process to make sure that if they have 1 of 10 symptoms, including exposure to someone who may or does have COVID, they need to not come to school. Now, whether you do that as an attestation, text message blasts, paper, rely on good faith, that's a complex set of considerations with you and your community. But you should have people every day thinking that if they have a new stuffy nose and body aches, they should not come to school. That is a violation of community trust, and that puts people at risk, even with masks. So, how you get there, we give some ideas on that, but there's there are a lot of different ways.
I'll just note on TLA's end, we've been thinking a little bit about how to integrate the daily screening process as a trigger for transportation and or triggering remote contact with a student. So are there ways we could actually be doing, like daily attestation through a Google form from a family, assuming you all have devices, that would then actually integrate with some of your SIS systems. So if anyone's thinking about that or has ideas, we'd love to hear from you.
Other thoughts? I hadn't been following Zoom chat so closely, so if you want to just speak to any of your comments, questions, that's helpful too. Also happy to give you 5 minutes back so you can do your thing.
This is John again. If I can be so bold, our local, I appreciate what you've mentioned about following our local county and state guidance. And this has been maybe one slight tension point for us is our local county has said 1 to 10 is the ideal ratio in a classroom. And so our teachers have latched onto that ratio as kind of a central request for us as a district to think about 1 to 10. And I've seen other numbers here, such as 25 to 30 and things like that. It's probably impossible to say, but is there a different ratio we could be working around that helps kind of ease teachers' minds of saying, well, we've got to get 1 to 10 or else we're not safe in our county or not? Yeah,
I think that the issue more is the geometry of space and distance, in the sense of I don't know where 1 to 10 would come from. The truth is, I can't give you a paper that says it should be 25, but we definitely can point to evidence that it shouldn't be 50 and it shouldn't be 100. I think the question is deciding on a distance threshold that you'll make the radius between the circles of 2 people, and you know, deciding if that's going to be 6 feet, then that, depending on your space, is going to dictate how many people you can rather safely put in there. If it's going to be 5 feet, that will dictate. I don't know if that's what's driving the 10 to 1, but our calculations in some classrooms we've seen would suggest it could be higher. We know, of course, some classrooms are really small, and we can get that. I think that the key in any of this is to look at some of the basics like universal mask wearing, you know, ventilation practices, and, you know, triage practices that can bolster where you have to necessarily make compromises, right? If you compromise on the space between people, maybe you can double ensure your efforts are maximized in the ventilation and mask areas, for instance.